Also, I'd just like to point out, James, that many of the guidelines suggest that only lower risk patients should be treated with erythroid stimulating agents.
Right.
However, there are many, you know that the incidence of transfusion-dependent anemia for lower-risk MDS is actually lower than it is for higher-risk disease. So higher-risk disease actually requires more supportive care. And even though we may think that at diagnosis, according to the IWG criteria, the patient has a higher-risk disease, but as we discussed earlier, those criteria are not etched in stone. They are correct maybe 50% of the time. So it's like throwing up dice. 50% chance of that patient really having higher risk disease, 50% chances that they look like they have high risk disease but could go along for a long time. So I don't think there should be such a hard and fast rule that if they have this, we should give ESA. If they don't have this classification, we hold it. No. As you pointed out earlier, James, we see the patient, we judge the patient, we look at the natural history of the disease, we look at the EPO level, we look at the transfusion requirement, and irrespective of what their risk is, we go ahead and we treat the patient.
No, I like that point. I think it comes back to something that we discussed a few minutes ago, which is that you do have to be patient early on to see how the disease will evolve. And I think have a low threshold to repeat a bone marrow biopsy after 3 or 6 months if something doesn't make sense, or if the cytopenias are worsening, or to really confirm that you know what you're dealing with. And that sometimes helps you know if it's higher risk disease or not. The issue of transfusion support in the higher risk disease is underemphasized, and you're absolutely right. And to me, that's a trickier area because it's a reason to start a disease-modifying treatment like a hypomethylating agent in the hopes that we'll get a transfusion response as well. So we tend to go to a systemic therapy with azacitidine or decitabine, for instance, rather than an ESA with higher risk disease to try to address the anemia. And I know there are some combination data, not a lot, but I think it's an important point that that's a very big symptom burden for patients with high risk disease.
I want to ask you a question.
Yes.
What
I'm the moderator, though.
I know, but you are also a hematologist I respect. So I want to know what's your practice. If you have a patient with, let's say, deletion 5q, isolated deletion 5q, the patient is now, hemoglobin is trending down, and you know you sooner or later, sooner rather than later, you have to do something. In that patient, would you begin by starting lenalidomide because that is the FDA-approved treatment for them, or would you start with ESAs?
That's a really great question. I would typically use lenalidomide to address the anemia. If there's another cytopenia, lenalidomide's tricky. But I would typically start with lenalidomide because I think it works faster. And even though there's not a lot of data for this, I think that the patients who do respond, and 2/3 do respond, I think the patients who respond have a better prognosis. They seem to live longer. And you know, I want to make people feel better. I want to make people live longer. Those are the two things I want to accomplish. So if I can get their hemoglobin up and try to get a survival improvement, then that's meaningful to me. Now, I realize this is off of a phase 2 study, and there's no randomized study to show that. But I like the fact that the responders do better in long-term follow-up. And when you look at the data with an ESA alone, it doesn't seem like that really modifies the natural history of the disease. And I don't know if that's what your reading is as well. And so that I think lenalidomide is a good option in that situation. But you can fall back to an ESA and I think still get people to respond if it doesn't work. And I don't think there's a rule that says you have to do one versus the other. That's just our reasoning for doing that. That's a great question, though.
But I do just the opposite.
Yes, I knew you were going to say that. Yeah, I suspected you would say that.
So I think it's a good thing for us to have this kind of a debate, simply because there's no one way of doing the correct thing right now in MDS in many situations. And I think it's important for our colleagues all over to realize that just between the two of us, we have a completely different management style. So when I have a patient who has an isolated deletion 5q and they start trending down, I feel that, look, we don't have 10,000 drugs for them. We don't even have 2 drugs for them. We have 1 FDA-approved drug and 1 supportive care agent. So let's try and get mileage out of both. why not start with an erythroid stimulating agent and let's see if they, especially if their EPO level is low, see if we can get some improvement out of that. Maybe we can get 6 months, a year, 2 years of remaining transfusion independent. Actually, I have gotten in some patients more than 2 years. And then once they stop responding, we either add lenalidomide or stop the agent completely and then just come in with. So this way you have this sequential use of relatively non-toxic therapy first, and then with a slightly more toxic therapy, which has some myelosuppressive effect earlier on at least, and then things settle down. So I feel that, and I'm not saying that what you're doing is wrong at all, because what you said is we can always use ESAs afterwards if the patients don't respond. And I'm saying, yes, we use ESA first and then go to lenalidomide.
Well, no, that's really an excellent perspective. Thank you for that. I was going to ask you another question in that same, I wanted to make a comment in that same vein that maybe the ECOG E2905 study will help us learn about the combination of the two together with prospective data. And
ESA and lenalidomide.
Yeah, that might be helpful also in combination.